Thank you. I'd like to thank the Society for asking me to speak in this webinar. And the title I've been given is Managing Menopause in Women with Chronic Medical Conditions. So this is my presenter's disclosure. And the conditions that I've chosen to cover today are shown on this slide. So looking at common chronic medical conditions, we've got osteoarthritis, osteoporosis, hypertension, diabetes mellitus, that's basically type 2 diabetes, and then patients with pre-existing cardiovascular diseases. So this is what I'd like to cover during this presentation. Obviously, I am not dealing with any conditions associated with cancer or neurological conditions. So I'm just sticking to these ones because these are the ones I know a little bit about. So we start with osteoarthritis. And this, of course, is a very common condition in both men and women, and a condition that as we get older, we're all going to develop to some extent. In terms of osteoarthritis and women, then it's more common in postmenopausal women than in premenopausal women. And this has been shown even allowing for age differences. So there does seem to be an effect of menopause itself on the osteoarthritis development. Osteoarthritis increases in females more than in males after the age of 50 years. So again, you're talking really about the onset of menopause having a significant effect. And it's more common after hysterectomy. And finally, ovariectomized sheep develop knee cartilage changes that are not seen in intact or estrogen replaced sheep. So this is just an animal model, actually, again, suggesting that estrogen and lack of estrogen will have an influence on the development of osteoarthritis. And on the right-hand side of the slide here, this is just showing you the incidence of osteoarthritis in the hand, in the knee, and in the hip with increasing age, so that even premenopausally, women are starting to get a degree of osteoarthritis. But of course, after the menopause, this goes very, very high. Now, we know that estrogen has direct effects on collagen, and so this obviously would be important for the development or preventing the development of osteoarthritis. Estrogen also has effects on cytokines, which are important, again, for collagen control, and it has effects on matrix metalloproteinases, which will also affect joint collagen. And we know from observational studies that HRT can reduce the prevalence of osteoarthritis. And you can see the figure here is an odds ratio of 0.76, and that is a significant reduction. And there is also evidence that HRT reduces the radiological progression of osteoarthritis. So in terms of patients that are developing osteoarthritis, if they're postmenopausal, if there's any other reason to prescribe hormone replacement therapy, it's likely to have a beneficial effect for this condition, although the prevention and treatment of osteoarthritis by HRT is not a licensed indication. And this study just shows you, looking at a marker of collagen resorption using these biochemical markers. And you can see here in this placebo-controlled trial that both oral hormone replacement therapy and transdermal hormone replacement therapy actually reduce the marker of collagen resorption. So it's just demonstrating biochemically that we're having a beneficial effect. So that really is the situation with osteoarthritis. So now let's move on to osteoporosis. So this is another skeletal condition, obviously. And this slide from Sirius shows the distribution of bone mineral density T-scores shown along the bottom axis here. So from -1 and above, these would be normal values. From a T-score of -1 to -2.5 is what we call osteopenia. And then below -2.5 is osteoporosis. And if you look at the gold columns, then that is showing the fracture rate per 1,000 patient years. So this is the fracture rate. And what you can see quite clearly is that as the bone density gets lower and lower, the fracture rate increases. And the highest fracture rate, of course, is seen in the patients that have got the most severe osteoporosis. But if you look at the turquoise columns, this is showing the number of fractures that are occurring at these different bone densities. And you can see that, in fact, in terms of numbers of fractures, then the biggest numbers are occurring in women who've got osteopenia rather than full-blown osteoporosis. And the reason for this, of course, is purely in numbers, that you've got far, far greater numbers of women with osteopenia than you have with osteoporosis. But it just serves to emphasize the point that if we want to prevent fractures, then we may be best targeting women who are at increased risk for osteoporosis, as shown by their osteopenic bone density, rather than just going for the women with established osteoporosis, who, of course, will have the higher rate of fractures. Now, most regulatory authorities have demoted hormone replacement therapy to second-line therapy for the prevention of osteoporosis. And to my amazement, this hasn't been reviewed. As I've just pointed out, the greatest number of fractures are occurring in non-osteoporotics, in women with osteopenia. Primary prevention of fractures should prevent all fractures, including hip fractures. So if we're using any agent for the primary prevention of fractures, they've got to be able to prevent all fractures, not just spine fractures, but including wrist fractures, hip fractures, and any other classic osteoporotic fractures. And of course, for any therapeutic agent, fracture prevention should be evidence-based. So let's just look at this idea of second-line therapy. Well, these are data from the US Women's Health Initiative. These are postmenopausal women who took part in the randomized prospective trials of WHI, women aged between 50 and 80 years, who were not selected because they were osteoporotic. So the vast majority of them are probably going to be osteopenic rather than osteoporotic. But nevertheless, the HRT results in a significant reduction in these women in hip fractures, in spine fractures, and indeed in any other fractures. So for these not necessarily osteoporotic women, but probably osteopenic women, HRT is causing a very significant reduction in the incidence of fractures. Now, these are data from Klaus Christiansen's group in Copenhagen. These are healthy postmenopausal women who took part in randomized clinical trials of HRT or placebo, looking at changes in bone density. And when these women were recruited, they were around about the age of 50. They were just early postmenopausal women, and they were randomized to either HRT or placebo for a 2 or 3 year studied treatment, looking at different types of HRT. Having taken part in the trials, they were then followed up for up to 15 years following their participation. So now these women who are aged about 65 years, and these are women that, having taken part in these studies, did not have any subsequent bone therapy. So they didn't have any further HRT or any other bone active agents. And if you look at all fracture incidents in these women, you can see that the ones that were randomized to HRT have got a significantly reduced all fracture risk compared to those women that have been randomized to placebo. So that shows you the odds ratio here of just over a 50% reduction in fractures if they were given HRT rather than placebo, and showing the spine fractures here as well, similar order of magnitude. And from this study, the numbers needed to treat to prevent any fracture with HRT was just 7. But these are still obviously quite small numbers, but nevertheless, what I think it illustrates is that we may get lasting prevention with just a few years worth of HRT around the time or soon after the time of menopause, that certainly will last for a good number of years. So in terms of osteoporosis, it would seem that HRT is extremely effective in its prevention. So what are the alternatives? If HRT is a second line therapy for prevention of osteoporosis, what do we use to prevent osteoporosis as first line? Well, the bisphosphonates are obviously the candidates, because these are widely used for the treatment of established osteoporosis. But in fact, there is very little evidence to suggest that you get hip fracture protection in women given bisphosphonates who are not actually osteoporotic. In terms of tibolone, which would be another alternative, there are no hip fracture data. It's been shown tibolone to reduce spine fractures, but there have not been sufficient data to show reduction in hip fractures. Doesn't mean to say it doesn't occur, just that we don't have the evidence. In terms of the selective estradiol receptor modulators, then big studies have clearly shown that although you get a reduction in vertebral fractures with the SERMs, there is no significant reduction in hip fracture whatsoever. Calcium and vitamin D supplements really have very little effect in non-elderly women. Parathyroid hormone and its analogues, so far there's not been any sufficient data to show protection against hip fracture. And the problem, of course, with this particular therapy is its very high cost. Strontium ranulate also has not been shown to prevent hip fractures in non-osteoporotic women, purely because the studies haven't been conducted. And then other things like phytoestrogens or any of the other so-called alternatives, there are just no fracture data, so we have to ignore those. So when it comes to primary prevention for osteoporosis, I'd say all of these are not suitable. So there is nothing for primary prevention, and therefore we're in the first line, and therefore we have to go straight to the second line, which would be hormone replacement therapy. Okay, so that's finished with skeletal conditions. Let's move on now to another very common chronic condition, hypertension. In terms of giving HRT to women with hypertension, or indeed women without hypertension, if we look at what happens to blood pressure, then basically we see usually either no change in blood pressure or often a small decrease in blood pressure with HRT. And these effects, as I'll show you in a minute, may vary with the type of progestogen that is used with the HRT. an increase in blood pressure has very, very rarely been reported in response to HRT. It seems to be an idiosyncratic response. It seems to be slightly more common if it occurs with conjugated equine estrogens rather than estradiol 17 beta. But the important thing is it is very, very rare. And if it occurs as an early event. And I stress the importance of that, is that if you've got a woman who is taking HRT, say she's been on HRT for 5 years, she was normotensive when she first went on to the HRT and has remained so, but 5 years down the line, she starts to get an increase in blood pressure, then this is not due to the HRT. And please don't let any doctors say, oh, you must come off your HRT because your blood pressure is going up. In this case, it is nothing to do with the HRT. So just make sure that our local friendly cardiologists don't start pulling our patients off HRT if blood pressure starts to rise later on. These are data from a study from David Archer and colleagues looking at estradiol 17 beta given orally 1 milligram, either on its own or then with the addition of drospirenone, which is a progestogen that has anti-mineralocorticoid effects. So what you can see in terms of blood pressure, that just the estrogen alone is causing a significant decrease in systolic and diastolic blood pressure, small decreases, but they could be clinically significant. But when you add the progestogen to the estrogen, you get a significantly greater reduction in both systolic and diastolic blood pressure. So in terms of patients with hypertension, it is clearly perfectly all right to give them hormone replacement therapy if they need it. Another common chronic medical condition is type 2 diabetes mellitus. So if we look at the effects of estrogen and progestogens on glucose and insulin metabolism, we see some interesting things. Conjugated equine estrogens at the standard doses tend to be fairly neutral in terms of glucose tolerance. At high doses, as were used in the past, 1.25 or even 2.5 milligrams, they actually impaired glucose tolerance. In terms of estradiol 17 beta, then oral estradiol 17 beta tends to improve glucose tolerance. Transdermal estradiol 17 beta is either neutral or just a slight improvement in glucose tolerance. Conjugated equine estrogens increase the insulin response to a glucose challenge, which is an unwanted effect, whereas estradiol 17 beta given orally gives a clear decrease in insulin response, and to a much lesser extent if you give the estradiol 17 beta transdermally. So what we're seeing here is a difference in effects on glucose and insulin between these two different types of estrogen. Now, if we add a progestogen, we modify the effects so that oral androgenic progestogens increase insulin resistance. That's if they're given orally. From our studies, we would say that transdermal norethistone acetate, which of course is an androgenic progestogen, but given transdermally, it has very little effect on insulin metabolism. And there were 1 or 2 studies that have said it might have a minor beneficial effect on glucose and insulin. Medroxyprogesterone acetate, on the other hand, although this is a C21 progestogen, it does have androgenic effects, and it has an adverse effect on glucose and insulin metabolism. Whereas the non-androgenic progestogens, micronized progesterone or the very similar dydrogesterone, really have little or no adverse effects at all on glucose and insulin. So if we're thinking about HRT regimens to be given to patients who've got diabetes, we need to bear these differences in mind. And I'll just show you some data from some of our studies. on this. So this is a study that we did comparing oral and transdermal estradiol 17 beta with the cyclical addition of norethistro and acetate transdermally on this side of the slide or orally on this side of the slide. So with the transdermal estradiol 17 beta, there was no change in insulin sensitivity and no significant change when the norethistro and acetate was also added transdermally. With the oral therapy, you can see that oral estradiol causes a significant increase in insulin sensitivity. Now, that is the opposite of insulin resistance. So you're improving insulin sensitivity. In other words, you are markedly decreasing insulin resistance. But when we add the androgenic progestogen, norethistro and acetate, orally, you can see that that improvement is abolished. So we're getting a good effect of oral estrogen, but the addition of the oral androgenic progestogen has this adverse effect. Another of our studies, but this time looking at the effect of estradiol in combination with the non-androgenic progestogen, dydrogesterone. And here we're looking at oral glucose tolerance testing, and these are areas under the curve following the glucose challenge. And this is a 2-year study that we did, and you can see that in terms of glucose tolerance, there is absolutely no change whatsoever over the 2 years. But when we look at the insulin responses, there is a significant and steady decrease in insulin response to the glucose challenge, implying that you're needing less and less insulin to maintain normoglycemia. So in other words, it's suggestive of insulin resistance being reduced, insulin sensitivity improved. And if we look at the effect of HRT and on the incident diabetes, type 2 diabetes, there are a few studies now that have shown a protective or preventive effect of HRT on the new onset of type 2 diabetes in postmenopausal women. This is the HERS study, the heart estrogen replacement study, that was 2,700 postmenopausal women with established coronary heart disease, mean age of 67. They were followed for just over 4 years in this randomized placebo-controlled trial, and they divided they looked at the baseline fasting glucose levels. So if they were below 6, then they were normal. If they were between 6 and 6.9, they were regarded as impaired glucose tolerance, and above 6.9 would be diabetes. And what they found was that with the HRT compared with placebo, there was a significant reduction in the new onset of diabetes in this study group. And what we're showing here is the new onset of diabetes as shown by abnormal glucose levels rather than self-reported diabetes. And you can see that if at the start of the study they had normal fasting glucose, there was still a significant reduction for new onset diabetes in those that were taking HRT. Those that had impaired glucose fasting levels at the start of the study, again, a significant reduction in the new onset of diabetes compared with placebo. And if we combine these two groups together, then you've got a highly significant reduction, about a 50% reduction in new onset diabetes. And as I say, other studies have shown this, including the Women's Health Initiative with the estrogen progestogen, that also showed a reduction in the new onset of diabetes in their study for those women taking HRT compared with placebo. And I'm now going to move on to women with pre-existing cardiovascular disease, because again, this is going to be one of the most common chronic medical conditions. I'll start with looking at patients who are at high risk for venous thromboembolism. What can we do in terms of HRT? Can we even give it to them? And here I'm particularly thinking about women who have got obesity, who are also at high risk for venous thromboembolism, but any other conditions as well. So these data are from Pierre-Yves Scarabin, observational data looking at oral hormone replacement therapy and venous thromboembolism. And what they show is that with oral HRT, you get an increase in the venous thromboembolism risk during the first year of treatment. So as soon as you start the oral HRT, you're increasing your risk of venous thromboembolism, but over a 12-month period, this starts to settle and it's starting to return towards normal after about 12 months. And this is not surprising, because when you first give oral estrogen, it's going to have effects on both coagulation and fibrinolysis, and you are perturbing a physiological system that is normally in balance. And like with any other physiological system, if it gets perturbed, then with time, it starts to rebalance itself. And so that's why you're getting a decline here. This risk is dose dependent, and you can see in these observational data, a slightly higher risk with higher doses compared with the lower doses. And that has been shown to be a bit clearer and more marked in other studies. What is important is the route of administration, because I pointed out that their studies are showing that oral HRT administration leads to an increase in venous thromboembolism. No HRT is shown here as a relative risk of 1, and giving the HRT transdermally is exactly the same as not giving HRT. There is no increased risk of venous thromboembolism, certainly at the standard or lower doses of transdermal HRT. But not only is the route of administration important, also the type of progestogen that is added to the estrogen, and that is also important. And these are data from the UK's GP research databases, looking at the effects of different HRT combinations on the risk of venous thromboembolism. So these are showing hazard ratios here. There's the baseline hazard ratio of 1. And what you can see is that a combination of conjugated equine estrogens plus medroxyprogesterone acetate actually has the highest increase in VTE risk. Conjugated equine estrogens plus levonorgestrel is still significantly raised, but slightly less. Estradiol plus medroxyprogesterone acetate, also an increased risk, but slightly less again. Looking at this bar, this is oral estradiol plus dydrogesterone, and this is the only oral combination that is showing a non-significant increased risk of venous thromboembolism. And lastly here, we've got estradiol, oral estradiol plus norethisterone, about the same as with the norgestrel. And here is tibolone not showing any increased risk at all. So with this study, one can conclude that oral HRT, one has to be very careful in patients with increased venous thromboembolism risk. But if you have to give it orally, then probably the combination of estradiol plus dydrogesterone would be the safest one to give. And of course, this is important because if you're thinking about the effects of giving HRT to a type 2 diabetic, then they are often overweight or obese, so they may well be at increased risk for venous thromboembolism. As I showed you earlier, in some cases, one would like to give the oral estrogen rather than the transdermal estrogen because of its better effects on insulin sensitivity. But clearly one has to be careful, and often one would have to go for a transdermal regimen rather than an oral regimen, with the exception of the oral estradiol dydrogesterone combination. So what about patients at high risk for cardiovascular events? If we look at the HERS trial again, and I showed you the data for new onset diabetes, now we're looking at the effect on coronary events in these women. So 2,700 postmenopausal women, all of them were beyond 6 months from their last cardiovascular event, and they're all women with established coronary heart disease, randomized to conjugated equine estrogens 0.625 milligrams plus the continuous medroxyprogesterone acetate 2.5 milligrams daily. This is quite a high dose, I think, of conjugated equine estrogens to be starting women in their late 60s and 70s. The event rate was slightly lower than they were estimating, and the mean follow-up was just over 4 years, whereas they had estimated that they would need a follow-up of 4.75 years had the event rate been 5%. So clearly this study is not going to be able to show any significant effect on coronary events. And of course, the bottom line was that they showed no overall benefit that was seen. But if we look at the year-by-year breakdown of events, HRT compared with placebo, so starting here with a relative hazard of 1, of course, at the start of the study, and after the first 12 months, there seemed to be an increase in coronary events in the HRT group, but thereafter there was a steady decrease in events, and this trend downwards was statistically significant. But what I think is more illuminating is to look at the trend of events as they went on. So here we've got cardiovascular events as a percentage at the end of year 1, the end of year 2, the end of year 3, and the end of year 4. And the green line is showing the hormone replacement group. And you can see that there clearly is a steady decline in events with the HRT. Whereas with the placebo, one would probably expect to see a straight line, but in fact, we're seeing an apparent increase between years 1 and years 2 in placebo, which is rather strange. So when we're looking at the end of year 1, are we seeing an increase in events in the HRT group, or are we, for reasons we don't know, actually seeing a decrease in events in the placebo group? Because thereafter, the event rate is fairly steady in the placebo group. So we're left with a bit of an unknown there. This is a study that we did at the Royal Brompton Hospital in London. This was with our colleague Giuseppe Rosano and Pete Collins, and they were looking at the effects of giving estradiol to women with established coronary heart disease and looking at its effects on myocardial ischemia. And they did this by looking at the ECG exercise test. So these women with established coronary disease are put on a treadmill and are exercised, and we're looking for ECG evidence of ischemia as shown by 1 millimeter ST segment depression. And what you can see with this study was that with placebo here, this was the time it took to get the myocardial ischemia, whereas when they were given estradiol, it took longer. So the time to myocardial ischemia was actually prolonged. It was improved. And indeed, that's reflected by the total exercise time that these women were able to maintain on the treadmill, significantly higher in those given estradiol to when they were given placebo. This was a crossover study. So this is giving us clear evidence that HRT can actually benefit myocardial ischemia. So if we've got patients with established coronary heart disease and they've got angina, and we need to give them HRT for any reason, then it is quite possible that we could get some benefit. Certainly, we wouldn't be getting harm. Are there any data for looking at myocardial infarction and HRT? Well, not really. I mean, obviously, we can only look retrospectively at the effect on, for example, myocardial infarction survival with HRT. And this study from the United States, big study, nearly 115,000 women with confirmed myocardial infarction, aged greater than 55 years. So you can pretty well say these are postmenopausal women. Only just over 6% of them were on HRT at the time of the myocardial infarction, but that still gives us over 7,000 women. And what you can see is shown by the graph on the right-hand side is that in terms of percent death, those women who were taking HRT at the time of their myocardial infarction had a significantly better survival than those who are not taking HRT. And there's the adjusted odds ratio, a significant reduction in deaths from following myocardial infarction. So this is probably as good as data we will get, because we're not going to be able to do a randomized trial recruiting women who are intending to have a myocardial infarction. So this is all we can show. But the point is that it's not showing any harm. If anything, it's actually showing a benefit. And we know that for women who've not got established coronary disease, but just normal postmenopausal women, huge studies from the Finnish National Register, over 90,000 postmenopausal women who had taken HRT for up to 9 years and have died from coronary heart disease. And what the authors did was to divide the women up according to the age of onset of HRT. So those women initiating HRT below the age of 60 are showing a significant reduction in coronary heart disease death compared with women initiating the HRT above the age of 60. Now, I would point out that this reduction is not significant, but more importantly, we're not seeing an increase in coronary heart disease death, even in these women starting their HRT at a later age, and starting at the younger age, a significant reduction. And this is one of many reasons that I think that if we need to give HRT to women who've got coronary heart disease, then we can probably do it, providing we are very careful in our choice of hormones, possibly the route of administration, and certainly the dose at initiation, depending very much on the closeness to menopause that these women are. And lastly, I want to show this slide looking at all-cause mortality, because I think this is just very important. This was a Cochrane review from Boardman and colleagues, but this has been supported also by the data from the Finnish registries. And what you're seeing here is 37,000 almost postmenopausal women exposed to HRT for up to 10 years. And the authors divided them again, this time according to initiation of HRT in terms of how close to the menopause were they. So initiating within 10 years of onset of menopause, you're getting a significant reduction in all-cause mortality, whereas initiating beyond 10 years post-menopause, you're not seeing any reduction in mortality at all. But equally, you're not seeing any significant increase in mortality. You're just not seeing the reduction. And that's the important thing. So all-cause mortality being reduced by HRT, I think is a very important thing to bear in mind. So when we're thinking about giving HRT to women with chronic conditions, chronic medical conditions, then we can be fairly comforted by thinking that this is a pretty safe treatment all round. And lastly, I just wanted to put this slide in just for a bit of fun. We all, from time to time, will get asked, oh, I've got a patient with such and such a condition. Is it safe to give HRT? And some of these conditions can be particularly unusual. I picked this one just I thought it's rather good fun. The Vogt-Koyanagi-Harada syndrome, which I've actually not a clue what it is, but it's something to do with some weird effect on melanocytes, and they get lack of pigment or increased pigment or something like that in the retinae and whatnot. It doesn't matter. It's an incredibly rare disease, and its incidence is about 1 in a million. So supposing somebody says to you, look, I've got a patient with Vogt-Koyanagi-Harada syndrome, but she's got menopausal symptoms. Is it safe to give her HRT? Well, we have absolutely no evidence to go on whatsoever. So what are we going to say? And this is my way out of this sort of condition, or this sort of question, rather. I say, well, if you've got this patient with the Vogt-Koyanagi-Harada syndrome, and she's premenopausal, is part of the management of the condition to remove both her ovaries to improve the condition. And if it's not, then it's probably safe to give her HRT. And this would apply to any other condition for which we've just got no evidence whatsoever. But I always think that's a pretty safe way out. In conclusion, I think that most postmenopausal women with chronic medical conditions can be given HRT if required. And obviously, there are certain medical conditions that I haven't mentioned, for example, estrogen-dependent cancers, where clearly you can't give HRT. But for the ones that I've been talking about, many medical conditions, I think you can give HRT if it is required. And the benefit for some of these conditions is certainly going to depend on the type of hormones that you give, particularly the progestogen, the dose of hormones at initiation of therapy, and that will be very much guided by what age you're initiating therapy. So the older the patient, the lower the starting dose of hormones needs to be. In other words, you've got to, in older people, you've got to start with much lower doses for whatever your aim of treatment is. And the routes of administration in some cases will be important as well. So I hope I've given just an idea of what we need to do in women with chronic medical conditions. For most of them, I think we're pretty safe giving HRT if they happen to need HRT. Thank you very much.
Thank you, Dr. Stevenson, for such a wonderful presentation. And now for the Q&A session, we will wait for a few seconds. I remind you that you can submit your text questions at the questions panel in your webinar dashboard. All right, our first question, Dr. Stevenson, do you think we can prescribe HRT just for cardiovascular prevention? I mean, we're talking about patients without contraindications, so around 50 years old.
Yeah.
And that has, yeah.
Certainly, I mean, my personal view is very, very much yes. And I think that the totality of the evidence we now have for prevention of coronary disease in postmenopausal women using HRT really is overwhelming. And so I believe it's not yet a licensed indication, but if you can think of any other reason to give a postmenopausal woman who is at increased risk for developing coronary disease in the future, think of any other indication to give her the HRT, then I would do it.
Great. All right. Next question. Well, thank you for your lecture. We have many people giving thanks for EMAS for having this presentation, of course, and for your presentation. Could you address HRT in the presence of hepatic cysts, probably benign, but that could increase with estrogen?
Yeah, I think in terms of hepatic cysts, then there is no evidence to say that giving estrogen would have any adverse effect on them. We know that oral administration of estrogen can affect the liver. So if you had concerns about any hepatic conditions, then clearly it would make sense to go for a non-oral, a transdermal route of administration. But I don't see that that would be a problem.
All right, our next question. Uh, Regarding Tibolone, Tibolone seems to be a good drug for MHT, but it is always underestimated. Where is the problem? Does it have to do with the stroke risk? And how much is this stroke risk?
Yeah, the Tibolone, we had a big randomized trial that was stopped because of an increased risk of stroke. It's difficult to interpret those data because the placebo group actually had a much lower incidence of stroke than would have been expected for their age group. So again, you've got this odd situation. Is it really that Tibolone was increasing the risk of stroke, or was it that for some reason the placebo group actually had a reduced risk of stroke? The other problem with Tibolone, though, is that it does have adverse effects on some of the cardiovascular risk factors, metabolic risk factors. It does worsen insulin resistance, and it is worse. We've published studies, a comparison of Tibolone with oral estradiol 17 beta combined with norethistron acetate, and the Tibolone certainly had a much worse effect in increasing insulin resistance than did that HRT regimen. And also Tibolone does not lower LDL cholesterol like standard HRT regimens will do. So there's really a good number of reasons for not choosing Tibolone as a standard HRT. But if you need to give Tibolone because you want its androgenic effects, particularly in terms of low libido and things like that, then providing there's no metabolic contraindication, then I think it's perfectly reasonable to try it.
All right, our next question is, in a woman over 60 years old with hot flashes who had never done HRT with some cardiovascular risk factors such as hypertension and pre-diabetes, would you screen for subclinical cardiovascular disease before giving HRT, and how?
Personally, I wouldn't screen for subclinical cardiovascular disease because, probably the way that we would do it these days would be to do a CT angiogram to look for coronary disease. But the problem there is that if they've not got any symptoms and you just show that they've got some coronary calcification, what are you going to do about it? And certainly it wouldn't stop me from giving them HRT if they needed it. So I don't think it's a good idea to screen for coronary artery disease before starting HRT, because it's not going to alter your management. And certainly at a woman age 60, yeah, I'd be happy to give her HRT. Would I start her, if she's diabetic, would I start her on oral HRT? It would probably depend on her lipid profile, because if she's got raised triglycerides, then I would probably be happy to give her oral HRT combined with an androgenic progestogen so that we don't increase the triglycerides further. Or we could give her transdermal HRT because that will reduce the triglycerides. But the transdermal will not have as big a benefit for the diabetes as will the oral, particularly the estradiol plus a non-androgenic progestogen.
Right. And what is your opinion about estradiol valerate, Dynagest COC?
Oh, right. Yeah. I mean, I don't have any experience with that particular progestogen, and I'm not familiar with any good metabolic data on it. So it's difficult to comment on that. I would probably say just be a bit wary of it and assume that it's going to have a fairly androgenic effect.
All right. And why give oral HRT at all instead of patches in everyone?
Sorry, could you repeat that question?
Why give oral HRT at all instead of just giving patches in everyone, to
Yeah.
everyone?
Okay, that's a very reasonable question. In terms of, for example, the skeleton and bone protection, there's no difference whatsoever between transdermal and oral. The only differences are going to be in terms of the metabolic effects and the thromboembolic effects. So if you've got somebody who has got metabolic syndrome or has got evidence of insulin resistance or is suspected to have insulin resistance, you may wish to choose an oral HRT above a transdermal HRT. If you're just giving estrogen alone, for example, one might want to give the oral therapy because that will improve insulin resistance much more than the transdermal therapy. And you have to balance this against the risk of venous thromboembolism. The risk of stroke is a bit more difficult because transdermal estrogen at above average doses may also increase the risk of stroke. So one just has to be very cautious. And again, we're coming back to the importance of dose at initiation. And that's probably key here to when the safety of the HRT.
All right. And what about MHT and good control diabetes type 1?
Well, for type 1 diabetes, there's no reason why you couldn't give hormone replacement therapy. They're going to be insulin dependent. It's not going to interfere with that. In fact, theoretically, giving HRT to a type 1 diabetic, if you're giving the right sort of HRT, you could even improve the insulin action because you're going to improve insulin sensitivity in the tissues. But there are no good studies that I know of looking at that. But I would certainly be prepared to just check that whether you need to actually even reduce the insulin requirements slightly when you go onto HRT. It would be very much an individual thing, and it's just something you would have to monitor in the individual.
All right. It seems that we do not have any more questions. Dr. Stevenson, are there any final thoughts you'd like to share with us before ending today's presentation?
No, I think that I hope my message basically is that hormone replacement therapy is a very safe and very effective treatment for a number of conditions, and that we certainly shouldn't be frightened of it. The data showing that all-cause mortality is significantly reduced by HRT cannot be underplayed. And to my simple mind, any treatment that makes you live longer can't be that unsafe. Thank you.
All right, this concludes the webinar. Thank you so much, Dr. Stevenson, for your presentation and all the attendees for being here today. Have a great rest of the day.
Thank you.